interact with something, there's a good chance if something is to go wrong, it will most likely happen in your hands. So if you're the one who's going to fetch water, if you're the one who's let me say leading the country, in charge of a ministry, chances are if something is to go wrong, it will go wrong in your hands. So it's a proverb that tells us, one, do not be afraid to interact with something. But it also reminds us of the delicateness of the pot. So if you've been given a duty, do it well and do it properly. Because once the pot breaks, you don't have water. And I think today is a classical case of perhaps where a pot has broken.
Right.
Yeah.
The pot is broken. Wow, that's okay. So we're starting from that. Gee, the pot is broken in terms of what we're looking at. If you look across our headlines today and what headlines have been looking like for the last couple of weeks. So Rufa has been saying, come on, guys, get this thing together. Otherwise, we're not going to be able to offer services. And it's not a matter of we're being sensational or overly sensitive or emotional. We just are unable to continue offering services in advance for you to then pay us in arrears. Unfortunately, you don't pay us in arrears. Even that's not happening. 70+ billion shillings unpaid. And this is where we are today. We're going to take a call at some point from Sharon Akinyi. And we'd like to hear from her first. We're going to ground this conversation in that. Okay. She's going to give us her experience in terms of what has happened with her trying to access medical services in the past. And she'll share that with us. And then it takes us to the place whereby we can understand what's going on and then the mechanics that then need to be applied to that conversation. And I don't know if we're ready to... Is it a go for you, Eve? All right, here we go. Good morning, Sharon.
Good morning.
How are you doing?
I am fine, thank you.
So we wanted to get some information from you. You've tried to access healthcare using your SHA card. Give us a little bit about your experience, where this was, what happened, and the condition that you currently are in.
Okay, I started using my SHA around July when I had some complication in my pregnancy. So when I went to Juja Modern, I was told that I had to clear the annual payment of the card, which was supposed to be 5,400, and I had only paid 1,350. So I was forced to clear 4,050 so that I was able to be admitted, because by then I had placental abruption, which was very emergency. So after paying 4,050 to clear the annual payment, I was admitted. I stayed there for 4 days. Now, when I was discharged, I was supposed to pay 27,000, which I thought SHA was supposed to take charge, but I was told that SHA only pays partly, and some I was supposed to pay in cash, which of course I did. I paid around 12,000 and some hundreds in cash that SHA was only to pay partly.
Sorry, Sharon, can I just confirm, up until this point, you had paid fully for the whole year?
Yes, I had paid fully for the whole year, 5,400.
Okay.
On July, I paid 4,050. That was the balance remaining to complete the whole amount for the whole year. But I still paid the cash when I was being discharged. That SHA couldn't pay all of the amount.
Okay, go ahead.
Yeah, so after that, I've been going for clinics, and yesterday, because of the complications of the pregnancy, so I was going so that we can book CS, which is scheduled for 3rd of October, next week on Friday. But they told me that SHA is no longer working, so I should be ready to pay cash by then if it is not resolved. And cash is around 50 to 70,000. That is what they told me.
Did they tell you the reason why you had to pay the extra 27,000 and that SHA was not going to be able to cover that? Did they tell you the reason why?
No, they did not tell me. They told me that SHA is covering partly and I will also pay partly, especially for the injections that I was given.
Okay, so you go back to hospital in October, essentially for delivery?
Yeah, I went yesterday to book for delivery and for some checkups. But now after booking, they told me that SHA is not working, unfortunately, as from yesterday. So they are not sure if by Friday, which is next week, it will be resolved. Now I asked them, if it is not working, what will I do? You will have to pay cash, which is ranging between 50 and 70,000, depending on how the CS will undergo.
All right. Now, so you're not quite sure what's going to happen, but what you do know is that you need to be prepared with cash come this October date when you will then present yourself to hospital to be delivered of your baby.
Yeah, which is already traumatizing me because this pregnancy has been with so much complications. Because when I started my clinics, I was not in Kiambu County. I was in Migori County. Now, when I came here, the complications came and I was told not to travel back home. So I can't travel. I can't go to a distance hospital. I have to go to the nearest hospital, which they already know my condition. We have worked through with them. So I'm just worried if I have maybe to go to a public hospital, which I do not even know which one is better, and going and starting to explain myself. It's traumatizing me, and days are numbered.
Okay, let's go to the last question. Last question for you, Sharon, before we let you go, because I would like you to keep listening in because Dr. Timothy is here. But just to confirm and clarify, you are paid up until December 2025?
It should go up to, I think, April or February next year, because I started paying in February.
And you've paid for a year?
I registered SHA from February, so it should go up to next year.
All right, Sharon, we're having this conversation. Yeah. Thank you for sharing this information with us. And I would encourage you to keep checking and see what happens as the days go by and see then what is possible. But try and listen into this conversation and let's see what we can do in terms of sharing the right information. All right?
Okay.
Thank you so much for patching into this morning. And let's continue with this now.
Okay.
All right, Dr. You've heard what she said. This is Kenyan. This is a yesterday situation for an October birth. This is what she's been told. What's going on?
I think it's unfortunate, and my heart goes out to her on what she's facing. And I'd like us to look at it in a different way. The first being that I'll take us back to the Constitution. In its preamble, it says we, the people of Kenya, isn't it? And there are a couple of things that it says, and one of them is that we do commit to nurturing and protecting the well-being of the individual, the family, and the community, and of course the nation. I think that's the first place we interact with health in the Constitution, in its preamble. And the people of Kenya have envisioned this for themselves. And through its agents who is the government, have said, go and deliver this for us. And I go to the second question, who is the government? And we have what the Constitution says, or who the Constitution says is the government, and who actually is the government. The government is the president and the people he listens to.
Right.
That's the government. And he listens to people by design and at times by force. For example, when a court of law speaks, you have to listen. When Parliament speaks, when it enacts a law, we have to listen. And that comes now to the rules that govern a republic, the rule of law. And therein, in our Bill of Rights, and it's actually under an economic, it's under the economic part that says we must have access to the highest attainable standard of of care or health. And it further goes to say that it recognizes that the government doesn't have the money for this, or all the money for this, meaning that the people who own the republic must in one way or another finance their health. And how do we finance our health? There are a couple of ways. One, through our taxes. We could do an out-of-pocket expenditure, or we could outsource this risk to someone else. Those are the ways we pay for our health. So healthcare is not free. All right. Now, the government has said, we know our Kenyans, we know our people, we know the diseases that they are most likely to suffer from, and we are undertaking to provide healthcare under this scheme, that is the Social Health Authority. So the Social Health Authority is essentially a trust, a social contract between the government and its people. Providers are just the underwriters of this social contract. And when it comes to healthcare financing, we have three people. We have the person who's seeking care, we have the person who's providing it, and the person who's paying for it. And it's often said this is a very unhappy triad because when one of them is happy, there's someone else who's not happy. But we can find a balance. And this is what we are asking the government to do. This particular case for Sharon, one, the Act says that you must pay for your premiums annually. It's not exactly cheap for most Kenyans. It is not. The second thing is there is a Lipa Pole Pole that has been brought as a consequence of that law. However, you must do 4 months upfront, and then the government, or rather that credit facility now kicks in. How many of our people can afford that? So I think it's now time we revisit the things that are working about SHA and the ones that are not working about SHA. And this is one of them. The second thing is there hasn't been the best of civic education or education around the benefits package and the tariffs that are attendant to it. And therein, we have access rules. So could this be a case of where the access rules were not clear for Sharon? All right? So...
She made it clear, though, Doc.
Yeah.
What are we talking about?
Yeah.
What did she say? She's paid her premiums up until February next year. She was told very clearly that when she went and presented herself to hospital, she was told very clearly, we'll pay for some, you pay for the rest. But, and this is perhaps where communication is not clear, coming from the governing authority of this, of health. When will you pay a little bit, and when will I pay a little bit? From what we understand, what has been public proclamation, I should be able to walk into hospital having paid my premiums and not have to pay a cent to be treated at whatever level.
Okay.
Whether I'm going in for outpatient care, whether I'm going in for inpatient care, and whether it's a hospital, an admission, or whether I'm going into critical care. It's been made clear that you don't have to pay an extra cent. But we have way too many stories of individuals who've been told, well, okay, that's great. You've been admitted for 14 days for renal failure and you had to be in ICU. Well, out of 400,000 shillings, we're going to pay 86. So why should it differ across so many lines all of the time? It is not clear to people when SHA will pay or when it will not, or when it will be split. It's not clear. And for me, it just, not just for me, but for everybody.
It's for many Kenyans, yeah.
For everybody,
Yeah, for many
you need
Kenyans,
to know what is going to happen when I present myself to hospital. In this case, private hospitals, that's out the window for now at least. But in a public hospital, if I present myself under SHA, what is going to be taken care of? It's not clear, and it must be.
Now,
Right now, it's clear as mud.
Yeah. Now, I'll straight off the bat, like I said, there's been a communication challenge by SHA, and it's something we've observed. When you're instituting change and change management, communication is what underwrites that process. So that is something that has been a challenge. All right. The second thing is we haven't leveraged on the partners that we have in the ecosystem. All right, and the biggest partner for SHA are the hospitals. The system that has been bought, the work that they do, the providers or the hospitals That is their biggest stakeholder, over and above the Kenyan, of course. But operationally, the providers are their biggest stakeholder. And I think it's in the interest of SHA to ensure that the providers are happy. How do you do that? First of all, there's a huge debt distress. I'll want to get that out of the table. There's a huge debt distress, and it's important that payment is made and made on time. SHA, as a social insurance, is not immune to the physics of the principles of insurance. All right? And the first principle is the one of utmost good faith. So when I tell you I will pay you, I better pay you, and I pay you on time and the amount that we had agreed on. Whereas there has been improvements in the process of that in terms of, let me say, visibility, because we often confuse visibility for transparency. There's been some visibility on what is being paid. However, we want them to go a step further. We also want them to tell the Kenyans, when you come to hospital, your claim was 2,000 shillings. We have accepted 1,800 for the following reasons. All right? Or we are rejecting for the following reasons. They should tell the Kenyans that, because those are the owners of the republic and they're the ones who are paying for this service. All right? So that we remove this you said, I said. Because as of now, the moment you come to hospital, a pre-authorization has been done.
Sure.
The provider is the one who's left with the back-end processes of that. And Kenyans at that point will say, SHA is working. And indeed it will for them. It will be for them because the service has been given. They've not been asked for money if it's a service that is fully covered by the benefit and the access rules allow for it. However, on the provider side, I am left with now the processes that are behind that. And at times, these claims are being rejected, even after pre-authorization has happened. So they will. One of the reasons that I have also picked up with the leadership of SHA is a claim that is rejected on the basis that the benefit has been exhausted. So the question I ask, how did it pass the pre-authorization process?
Absolutely.
Yeah. So there seems to be some things that they need to work on internally so that this process is smooth. So the second thing that I will say is on fraud, wastage and abuse. As the provider network, that is as a Kenya Healthcare Federation, we are the umbrella body for the private sector and we take care of the entire value chain. So even RUF are our members, the Christian Health Association, KCCB, all those people are our members. And the one thing that we are very clear on is fraud is a no-no. For two reasons. One, it's of course wastage of public resources. But more importantly, if you're fraudulent, it means that there is less in the pot to pay the ones who are doing the right thing. And I do want to say it's more people who are doing the right thing. Whereas there has been a conversation of fraud. This is being weaponized at the altar of fund solvency. And I'm coming to fund solvency. Adendwale has been very clear on this because he's been the most vocal person on fraud, wastage and abuse. And I support the conversation of fraud, wastage and abuse. It's something that we must kick out. However, it cannot be weaponized. He has styled himself as a bulldozer, which is a good thing. Right. But it's not only bulldozers that build roads. You need the truck that will have water to come in. You need the leveler. You need the one that will bring in the tarmac. It's an ecosystem. And what we are telling him is, let us build this road towards UHC together. It can't be a top-down approach.
But is it not a faulty concept from the beginning? Because guess what? On the 1st of October, which is in about 7 days from now, SHA would have been in existence operationally, fully operationally, air quotes, for a year. Is it possible that you have so many false starts and that you're stumbling along for a whole year for a system essentially that's supposed to be... We've been hearing SHA isn't working, SHA is working, SHA is not working for a year now. A year. It's been a year. And that we keep talking about teething problems, but you know what? The teething problems end. I keep saying that a child who's growing teeth, right? When it breaks the jaw, when it breaks the what is that thing called? You're a dentist.
Gum.
When it breaks the gum,
It erupts.
Thanks. The teething problems come to an end, and we move. The teeth start to grow, but we seem to be in teething problems for this thing for the longest time. So is it really just a communication issue, or are we looking at a fundamental flaw with the system whereby we know that money is not flowing the way in which it ought to? Because if people are paying their premiums, the residual effect is that we will get health care.
Yeah.
But that is not happening. And I keep saying, when we look at rejects in a clothing line, for example, if a button is off, it's thrown out. The thing is not, the full thing is dysfunctional. So it's removed. So can we say that if it works in part, then it's working? But if it doesn't, it's just that part that's not working. The whole system is dysfunctional.
I think, I'm at a loss for words when I
Today
start
you're
thinking about SHA.
Yeah.
The reason I'm quiet is there's so many angles to look at this SHA conversation. And it's because, listen to what Sharon, I'm just thinking, her voice is just still in my mind. She's in a space where she doesn't know what to do. So on one hand, you're told you're going to pay this much, SHA is going to pay this much. Then all of a sudden, SHA is not working. Yeah. So what is somebody like Sharon left to do? And I'm looking at just a very typical example. All of us have had medical covers. And I'm trying to remember a time when there was confusion like this, and I don't recall any. And it's simply because by design, when I'm taking a medical cover, there is the portion where there's enrollment, and it is very, very clear. So if you're enrolling, it is you as a person. Are you enrolling your family and joining your family?
M+1, +2.
Exactly. Then is the employer going to pay part of it and you pay part of it? Same thing we're looking at SHA. So there's a part where I have to pay, then the other part is the government that is going to cover. So here it's very clear in terms of their enrollment, who then qualifies and who caters for what cost. Then when we look at premiums, and this is the most important part, we look at premiums as a member. So there is either a fixed amount or there is what I'm deducted monthly, quarterly, and whatever. But now we come to coverage. The biggest confusion is actually what is covered, what is not covered. So when I'm taking an insurance cover, I know the policy clearly specifies to me the services that I can enjoy. If it's outpatient visits, this is how much has been allocated for outpatient. If it is inpatient care, this is how much is allocated to inpatient care. If I go beyond that, then I have to get the money from my own pocket. Then it tells me, if you want to go visit a dentist, this is how much is allocated for. If it is optical, this is how much. So where I'm sitting right now, if I have an eye problem, I know the amount of money I only have is 40K. If I go beyond 40K and the glasses that I want to pick is 70K, I know you're yangu. It is very, very clear. So we've cleared the issue of enrollment. We've cleared the issue of premiums. We've cleared the issue of coverage. Then utilization. I know my cover, I can go to hospital A, B, C, D. But if I go to this hospital tier 1, I may not necessarily get the services. So then the question is, by design, if this is how essentially covers are supposed to work, why is it so complicated for SHA to work in a similar fashion? So is it, now tying into what I'm doing, is it a design issue? A design meaning they've deliberately created chaos because somebody is benefiting. That's what I'm thinking. Somebody thrives from this chaos. Or two, like the president had said previously, there are people who don't know how to communicate some of these good things that the government is trying to do. So where was the breakdown? Where is the breakdown with this thing?
So if given a choice of getting something right or on time,
yes,
I'll choose getting it right so that we don't sacrifice accuracy or speed. And some of the changes that have been brought in should have been done sequentially and over some time. As a provider network, we'd even propose, let's do this over 2 years before you say we can roll out.
As a rollout phase?
Yes. Okay. Let's do it in 2 years so that we're able to take care of the teething problems and do as call them. The second thing is we've politicized healthcare delivery. Whereas politics is the art of the possible, medicine is reality. And we go to school to study health systems and all those things. Unfortunately, diseases don't read textbooks.
No.
They don't. They come in various forms. Our bodies also have variations from one person to the other. So that is a reality which we deal with. And when our dreams and ambitions clash with reality wins each time. Therefore, Mahanzo was here.
Yes.
And we are talking about by-elections. He's very clear. Register as a voter. But when it comes to SHA, why are we not telling Kenyans to pay as well? It's not only important to register, but it's also important to pay up. All right.
But you see that's where the problem is.
So that is a communication problem.
It's a communication problem, but there's also, you started by saying that there's also politics involved. When the president says, I mean, there's an authority. The president says, the minimum you people will pay is 300. The rest will be, you guys will be sorted. So what you're telling this somebody in the village, and what you're telling Sharon, for example, is with the complications you're going through in your pregnancy, you don't worry. You go to hospital. If you have paid, this is the minimum that you're going to pay. The government is going to pay the rest. Then she's told, oh, by the way, you will need to pay for a full year. So the breakdown in communication was not, you need to pay 4 months before you even go to the hospital. So and that's what a lot of Kenyans are doing. You're going to hospital, then you realize, I need medical care, so I need to pay. So when you're going to fill the forms, you realize it's not 300. For Sharon, it's what? She said 5,400.
5,400, right.
Not so many people can even afford that much.
That's true.
And then, so there is that. Then you get to a point where last week the president said in Mombasa, look, we understand that people are very poor and vulnerable and they're not able to pay. So because of this deficit, the government is going to step in and we're going to pay for those people who are poor. Then we are asking ourselves, so he's already announced that. So the people who have been paying, and somebody anasikia mimi ni maskini sitajiweza, so see the president alisema, serikali italipa. So this person goes to hospital. The president said actually the government is going to pay. Then he realized no, it doesn't work like that.
So I mean, correct communication problem. There's been a serious communication
But
problem.
is it deliberate? That's what I'm wondering.
I cannot speak into that. I don't work for SHA. All right, we interact with SHA heavily, but I don't work for SHA. However, there's been a communication problem, and I want to go to the next step of how do we solve it. The people who are interacting with Kenyans, again, is a provider network. That is the hospitals. How about we leverage that network to communicate to Kenyans better? I can assure you, if we have the goodwill, if we see the payments come in, this thing is going to sell itself. So conceptually, SHA has 3 things that are superior to NHIF. One, we have a primary healthcare component. That one is superior. 2, operationally, its spending is capped at 5%. Right? And then the third thing was that it was supposed to provide service to as many Kenyans as possible. Now, those 3 things, and I remember the president's advice on healthcare financing had said it will only work if the informal sector, the net captures as many people as it can possibly do so. 2, we are able to bring preventive healthcare services so that expenditure at higher levels of service are reduced. And then 3, payments there was a promise for payments to come in. Now, all those 3 things are under threat. And that is why, conceptually, SHA is facing some of the challenges that it does.
Doc, there's a question that Okari asked in the morning. And I think it's a question that I will pose to you.
Okay.
We have talked about SHA ever since it started. Every day on this show, there's always something
At
about
least
SHA.
clear.
You know? Question is, are we unable as a country, I'll not blame government, as a country or as individuals in charge of SHA for it to work, get into a room, say we're spending 2 weeks to fix the mess in SHA so that Kenyans can have a healthcare that is working? Because every day we say there's a problem here, there's a problem there, we need to fix these are not paying, we have many people who are registered and are not paying. Are we able to finally sit down and say, we are tired of this SHA communication and breakdown, that we need to finally fix it once and for all? Are we able to do that, or are we just unable?
One, we are able to do that. However, there has to be a cessation of hostilities. I have to be very clear on that. There has to be a cessation of hostilities. We can't be speaking at each other, yet it's the healthcare of Kenyans that is at the table. It saddens me that press conference after press conference, government is saying this, saying that, but we are not calling each other to the table. It is possible. And I really hope it's one of the things that we're able to do once the minister is back from New York, together with his permanent secretary. And one of the things that we've been very clear on is the debt. All right. If we are able to sort that out, because healthcare is a cash flow business, even for counties. And it surprises me that they are not as vocal as they should be, but perhaps it's because some of their operational functions are already underwritten by Kenyans through our taxes. But if they were to look at it strictly from a business point of view, it is not that providers are refusing, it is just because they can't. It is no longer tenable to do so. Remember, SHA is a first payer. If you have two medical insurance covers, SHA is a first payer. So from a business perspective, if SHA is a first payer and there are hitches in payment, that business is suddenly exposed anywhere between 10 to 20% of their book value to this super payer. Now, if there's any default that had not been projected, remember this has not been projected when we are doing our budgets, then what happens to that money? And remember, the moment that invoice has crystallized, KRA is on your door. All right, so you're already being asked to pay taxes on it. All right, of the 33 billion that is owed by NHIF, we've already paid our taxes, and we are not too sure that we are gonna get it back. All right. The second thing is that brings in trust issues, all right? And that is why there's a lot of hesitancy from the provider network, and there's also a component of that in the story that Sharon gave. That particular provider was like, I'm not too sure about this cover. All right. So there's a lot of hesitancy that is in the sector. So those are among the things that we must come to the table and have a very honest conversation on each of what is happening. If there's fraud, just say here is where there is fraud. This is what is happening, and we move and we move on from that. When a document has not been submitted, I don't think that meets the threshold for fraud. We should sit down and say this is what we are saying is fraud. And on that, I am having a meeting later on in the day to perhaps come up with a joint fraud action with SHA, so that we are able to say this is a threshold that this we are calling this fraud.
But even as we do that, Doc, because one of the things that you talked about, and we've said it here before, is that there's a call for folks to register for SHA, but then there's also a greater call for folks to pay.
Exactly.
So let's make the assumption here that, of the whatever number it is that they've said have registered in the millions, but in the low millions, have registered, we don't have the commensurate number of folks actually paying premiums. So let's assume that 20 million people have registered and that 20 million people have paid the 300, 600, 900, whatever the case may be, because we know that premiums vary based on your capacity in terms of your income. Now, would we see a cessation of these problems whereby hospitals are not paid, people go in and then we say maybe we'll pay half or not, or we'll pay a percentage of what your fee is? Is it a panacea to these problems, payment of people beyond registration?
You see, like I said, SHA is not immune to the physics of the principles of insurance. And one of them is pooling. You must pool your risk. And pooling is, we have as many people paying to the pot so that when you need to utilize what is in the pot, there's enough for everyone. So what is happening is adverse selection. So if you are registered, yes, you can access services at primary healthcare level at no cost. But the moment you need certain category of services, those ones must be paid for. And remember, most of our catastrophic health expenditure is happening in the higher levels of care. All right. Of the top 20 compensated surgical services, they're all orthopedic procedures. All right. So it could be from trauma or degenerative disease. That is arthritis or a broken bone, a hip replacement. Those are the top compensated procedures. So, and they're expensive. They're not exactly cheap. An implant, a good implant, is already 300,000. And that is the cost that SHA is paying for that entire procedure. So, again, comes to fund solvency. As long as what is coming in is less than what is going out, the problem has not been solved. And that is why I am of the school of thought. It is important we go back to the owners of this fund, and that is the Kenyans. And we tell them, it is not only important to register, it is important to pay. All right? And that is a message, I think, as a provider network, we are willing to carry, as long as the promises down the road are kept.
And you see, Doc, therein also calls upon, one would say, the political class, because you find every other time, especially at the registration of SHA, the political class went back to their people and told the people, you register. After registering, you will get services. They did not go further to say, after registering, you must pay for you to be able to access the service. Therefore, it is not only a conversation that we will drop on the service providers, not us, the media, but the entire system, the political structure has to equally carry this message the same way they told Kenyans to register. Like we say, kila mwamba ngoma huvuta kwake. Oh, that means it is.
I got it.
Yes, it is a drum. We are making a drum, right? And while making this drum, we must pull these hide so that the drum is made. But remember, the center is healthcare. If we keep on pulling, the center will crack. We need to go back and see how we add more hide on top so that even when you're pulling, we are able to offer these services to everybody else. It is not just about the healthcare provision, but us as Kenyans must jump on this ship.
And you've captured it very aptly, and that is what is going to ensure that there's fund solvency, so that SHA is able to administer this fund the way it had envisioned in the law. As long as that is not happening, then we're in trouble. The second thing is the payments and the payment cycles. The costings that had been done had very razor-thin margins, all right? So the moment you don't pay them on time, the time value of money is lost, all right? And suddenly you have debt distress, all right? The second thing is, if you look at our non-performing loan portfolio, I do want to say that the healthcare sector has gone up. Some of these hospitals are owed north of 1 billion shillings, all right? I mean, they have a bigger book value out in debt than even some of the microcredit and microfinances companies. As a sector, if we were to be, if we were to compare ourselves to the SACCO industry, I think we have more money out than the SACCO industry in 2022. All right, so it's a lot of money, right? So what we are imploring upon the president and the minister once they're back, let's have these honest conversations with each other. And one of the things that will enable this conversation to happen is payment.
Okay.
All right. And I'm not saying that to say money is at the front, but it's what is underwriting this. All right. The movement of money is what is underwriting this. And it is important that Kenyans understand that. We must tell them the truth. All right. As long as hospitals have not been paid, it is very difficult to ensure even quality of service. All right. And under the Bill of Rights, again, I still go back to the Constitution. The quality of the service that you're giving a consumer cannot be deliberately substandard. All right. So now it becomes a moral question. I have not been paid. Do I still continue to be in business? There's someone like Sharon on my door.
Yes.
I can give some sense of service to her, but I can't give it with guarantees. All right? Because the quality is not assured. So I want to remove that moral question from the floor if SHA is working.
So with all the trappings, I mean, it might be putting you in a bit of a fox's den, but with all the trappings, would you say that the NHIF system, which, by the way, interestingly enough, some of these hospitals who are shutting down services today are old from as far back as the NHIF period. Was NHIF as a system working better than what we see today, or are you saying give the thing a chance with this new operation?
There's something that Nikal said, and that was... you see, if when I left at home and I had a conversation and said, I'll come with guests for dinner, I must ensure that there is food for the guests, isn't it?
Yes.
However, in the course of my day, I can't meet Dennis and tell him to come for breakfast the following day if I hadn't ensured that there is enough breakfast. All right? So that it boils down to that. All right? If I leave the house and say I'm going to shop for a car, nothing prevents me from looking at a Range Rover or a Mercedes if my pocket can afford a premium. But I can't promise people at home I'm coming with a Range Rover yet I have premium money in my pocket. All right?
So you're saying you'd rather just stay with the vehicle that you have?
No, I'm saying it is important that we keep our word and keep the promise. All right?
Yeah.
The promise that we were given on SHA was being rolled out. It was going to be better than NHIF. Kenyans were going to get better category of services. And for me, the preventive aspect of it was the winner. And that is at primary healthcare level, because it begins and ends at the community for most diseases. So that is a promise that we were given. And right now where I sit, I am questioning that promise. All right? I am questioning the promise for payment on time. I am questioning the messaging to some extent now. And is it better than NHIF? NHIF had been here for more than 5 decades. We'd understood how it works. We had contributed as well to its workings. And even as of now, we are asking that we also be involved in the workings of SHA. Yes, there's been tremendous work that has gone into involving us in its workings. However, there are certain cautions that we've given that we are seeing now coming to pass. But the bottom line is, for a social healthcare scheme to work, as many people as can be in the net need to be in the net, and as many of them that can pay need to pay. You see, the proximity testing tool, if I'm to do it a little different, should be a tool that we agree on. This is the average fund premium. Right now it's at, I think, about 800 or between 800 and 900 shillings. We can agree that everyone pays that first. And then if you think you're poorer than that, then undergo the proximity testing tool. All right? If as government thinks you are richer than that, then they put you through that proximity testing tool. And the other thing that we can also use is a hybrid mechanism. Do we bring down the 2.75? And maybe, I suspect we are getting into a political season.
We're already there, Doc.
I suspect something may happen around this, but I would bring it down, but also go to the consumption taxes, so that everyone is paying as per their consumption as well. That way, we will be able to bring in more money. And this is what Dennis has said. Let's also communicate very clearly to Kenyans.
Yeah.
The truth is, SHA cannot cover all the diseases. That is just the truth. All right? And even where it covers the certain disease lines, it may not cover to the full extent. So Kenyans need to have this information very clear for them, because they have a good sense of understanding. They do have a deep and a good sense of understanding. So we should trust them on their understanding. And then thereafter, once I've said I'm going to pay 40,000 shillings for your teeth, I better have that money, because I am the one who has said I understand the disease patterns of the country. And this is the disease profile of the country. These are the epidemiological patterns that we are seeing. And up to, if I get 10 shillings, I'm able to cover up to here. So that is a message that today I'd want to bring out. The provider network is under huge distress. And payment is what is needed to sort out that.
I have a question.
Yeah.
When before SHA was rolled out, were the provider networks and all the other stakeholders engaged and involved before this thing was rolled out to begin with?
The answer is yes. We did give our input. Part of it was taken up, part of it was rejected. Unfortunately, the consequential bits are what we are seeing, some of them now. And one of the things that I really liked was the dispute resolution tribunal. That has not been set up. So it's important that is set up, so that we are not having a she said, he said conversation. If you think I'm not a good guy, take me to the tribunal so that we can have conversation. So you see, for example, what has been rejected by SHA, the 10 billion that the Honorable Cabinet Secretary mentioned, that should have been the subject of a DRT, the Dispute Resolution Tribunal conversation, so that we can say this has been a fair process. As of now, we don't understand, all right? And the contract says that SHA is supposed to do so in writing within 14 days. And remember, SHA is not operating on a credit basis with Kenyans. Unfortunately, if you don't pay for SHA, you don't access the service. There's no credit for you. But when it comes to the provider side, we have given it a credit line of 90 days. But even those 90 days, there's a spillover. we will have also, as the provider network, we'll have to go to the owners of this trust, and that is the Kenyans. And the conversation we are having with them, and I think that is what Rufa is alluding to, is the people who have been entrusted to pay for your healthcare. We are having issues with them.
In seconds, Doc, because our time is running to an end, and I know that you also have to go. Are we looking at a crisis? Because today means that you go to a private hospital and you will not get services under SHA.
Definitely, that's a crisis because Kenyans are not planned for out-of-pocket expenditure. Much as it's towards the end of the month, we have other obligations as Kenyans, and that is why we have insurance to hedge against these risks.
Indeed.
Yeah.
Dr. Tim Theory has been our guest this hour, just looking at the intrigues around SHA and what all of this means as we are getting into a season where things are a little bit sticky. The CEO of the Kenya Healthcare Federation has been with us this morning. Doc, thank you for doing this. I'm hoping that things will iron out and get clearer.
Yes, I'm having a meeting with the chairman of SHA today, so I am sure these are some of the conversations we've had. I must say he's been accessible for the difficult conversations.
Right.
Yeah.
Hopefully the difficult conversations will become solutions.
For sure.
Absolutely.
When we come together, as Safaricom says, great things happen.
Indeed. Good tagline. Safaricom will be proud of that. Thank you so much. It's 9 o'clock.
Yeah.
This is the Situation Room, the only way to start your day.